I'm Dr. Victor Hong, and I'm from Taiwan, and also I graduated in Spain. I'm now one of the instructors in Mediterranean Prosthodontic Institute, and also a dentist in part of Taiwan. So it's a great opportunity for me, and thank you, United Research Forum, for inviting me to share with you. I've been going to talking about management of peri-implantitis. This will be the recent research we've been doing, and also we have a lot of clinical cases to present to you today. So before we have a dental implant, we place the implant perfectly. We have everything in contact. We have the bone, we have the soft tissue, but sometimes after a few years or maybe half a year, we might have some plaque near the crown. So sometimes there's no bone loss. We could just simply clean it, or we could just remove it, or help the patient to do the oral hygiene care. And sometimes, well, if we did not take good care of it, it might have some bone loss, which is causing a peri-implantitis. So about a peri-implant disease, what we have from the health status to the peri-implantitis and peri-implantitis. And it will be, we'll be discussing today the reason why we have to treat the peri-implantitis. So back to the classification of periodontal and peri-implant disease and condition in 2017. The workshop have presented in a new form of the classification, one of the condition of the periodontitis and one of the condition in peri-implant diseases. So peri-implant disease, we have now have 4 sections. Section 1 will be the peri-implant health. The section 2, peri-implant mucositis, then continuing peri-implantitis, and the defects of the soft and hard tissue of the condition in peri-implant health. So we'll be talking about this part today, and to summarize the article for you, I have presented a small chart to let you know what is different between peri-implant health, peri-mucositis, and peri-implantitis. So the basic knowledge for us is when you have a healthy implant, there will be no bleeding, there will be no swelling, and no pus. But when you have a peri-mucositis, the patient doesn't take good care of the implant, or even they have a bone loss, a situation like a peri-implantitis, sometimes you will have the problem there. However, because the implant doesn't have nerves, so the patient will not complain anything. All we have to do is to check their radiograph recently. So to see the chart of the peri-implant health, more or less we have that problem depth around 3 to 4 millimeters. And sometimes in peri-mucositis, you have the same, but maybe you have the increment of the problem depth because of the swelling tissue. To mind here is that sometimes the swelling tissue may affect your problem depth, but it doesn't mean that implant has a bone loss. So the peri-implantitis, on the other hand, you have increment of problem depth, and also you have the recession of gingival margin. So this is a sign of a bone loss. So when you have a supporting bone loss of the implant, you could say the implant has affected by peri-implantitis. And the last section about the peri-implant soft and hard tissue deficiencies is the talking about how you will have peri-implantitis, sometimes because of the malpositioning of the implant, the lack of buccal bone, thin soft tissue, thin biotype, lack of keratinized tissue, and also a loss of attachment of the implant. So when we have to talking about the peri-implantitis, we have to know the 3 steps. The first step is you have a peri-implant health. That is the normal situation. There will be no bleeding or probing, no swelling, no erythema. You have adequate soft tissue. The mucosa is healthy. You have probing depth about 2 to 6 millimeters. Sometimes if you are placing the implant subcrestally, you might end up with a longer prosthetic. And of course, the most important part is no marginal bone loss through periodic radiograph. If you have peri-mucositis for the patient, sometimes you could only find these symptoms through clinically. There will be bleeding and probing, there will be swelling, there will be erythema, sometimes there might be a pulse, a suppression, and the patient might complain about uncomfortable of their implants. You could see the problem that might increase a little bit, there will be a flood accumulation, and also you will know there is something different than the normal situation. However, in a periapical radiograph, you won't see any bone loss. The bone remains perfectly, and the contact doesn't, there's an intact between the bone and the implant surface. When you have peri-implantitis, you will have a very visible sign of bleeding and probing, swelling, bleeding, and increase of probing depth, and also the chances of gingival resection. Marginal bone resection is also presented, and even though sometimes the soft tissue covers the implant, but you could see the metallic color through the gingiva. So when you have this kind of situation, you have to understand that this implant is infected, and you have to do everything to treat it. So when you're facing a peri-implantitis and also peri-implantitis, you have to know what is the first step to do. Sometimes the implant is the one you placed before. Sometimes the implant is done by the other doctors. So once you diagnose peri-implantitis and peri-implantitis, the first key is to do a non-surgical treatment. Just like periodontitis, we have to do root planing, we have to do scaling to the implant. Well, but in this case, we may use a plastic scaling tip or maybe a titanium curette, which I will show you later, to help the patient to do a cleaning in a non-surgical way. So by doing this treatment, you could understand how the tissue will react when the patient receiving this treatment. So when you have a good oral hygiene care, and also a good cleaning, sometimes you could have a good result after the non-surgical treatment. From according to the article from Reverse S from Sweden, they have published to talk about the peri-implantitis. You could have a probing depth reduction from 0.5 to 1 millimeters, and also the reduction of bleeding and probing. In peri-implantitis, you also have some reduction too, but it's a bit hard to control since the bone's already lost. So for the techniques for non-surgical treatment, like you could have some methods for non-surgical debridement using a plastic curette. You could do air polishing. This is also proved to be effective using a glycine sandblasting in recent articles. Laser therapy is also recommended, just like Dr. Shiva just told in the previous session. And also, the first of all, you have to remove the prosthesis to obtain the access to clean the implants. So from the same article, it's talking about non-surgical therapy is very good for peri-implantitis, although they have only a small effect to peri-implantitis, but it doesn't mean you don't do it. You have to always try the first step to do a non-surgical treatment to see how the patient reacts. If the patient had a good response, you could continue for further examination. If the patient doesn't have a very good response, you may think about the next step. So talking about the next step, about a peri-implantitis, is what we're facing, a critical peri-implantitis. Sometimes you might have a big bone loss, or maybe the implant is moving, or maybe there is a suppression over there, the patient has a problem, and patient feel the pain. How will you do? So one of my topic today is also to talk to you about EPDDS. So that is a concept, reconstructive therapy from unfolding peri-implantitis from Dr. Monhe and Dr. Wang Li from University of Michigan. So EPDDS is basically talking about the etiology identification of the peri-implantitis and how do you do the primary wound closure. Also, the debridement, the continuation, and stability of the wound during the therapy will be an essential target to treat this kind of problem. So I will be breaking down this concept for you to share with you. Excuse me for the time, so I have to go a bit quick. I hope you could keep up. So about EPDDS, the first thing is etiology identification. We have to know what is the reason causing the peri-implantitis. So the second step would be primary wound closure. We have to know how we could control this wound. How do we remove the bacteria, and then we have the primary wound closure for better healing. The debridement is very essential for treating the granular tissue or the infected tissue around the implant. And then we do the decontamination, what is the bacteria affecting on the titanium surface of the implant, and maybe also on the abutment or on the prosthesis. And then last, we have to know how to stabilize our wound after all the treatment. We have to make sure the wound is not affected, and we have the time for our tissue to regrow, to regenerate, and to reconstruct it. So to talk about etiology, we have lots of papers recently talking about the reason why we have peri-implantitis. One of the big section is plaque accumulation, and you also could have peri-implantitis because of lack of keratinized tissue. Maybe the implant was placed wrong. The position is a kind of mistake during the therapy. Maybe the prosthesis is improper design for a patient to clean, and there will be the obstacle for them during their oral hygiene care. Surgical trauma may be related to during the therapy, you might damage the alveolar bone, or maybe you damage the adjacent teeth, causing the bacteria to accumulate there. And patient characteristic will be the patient is smoking, or if the patient has a diabetes problem, it doesn't have to take care, you might end up with peri-implantitis as well. Foreign body reaction might be talking about the cement retained implants when the cement flows into the implant surface. However, the problem of these etiologies all ends up with plaque accumulation. So you may find some articles talking about plaque accumulation only, but because of these reasons, you have to identify the etiology first to know what is the main problem of your peri-implantitis. So continuing to primary wound closure. So when you have this kind of problem, you know the reason why causing the peri-implantitis. Then you have to know how you could close this wound for a primary healing from the body. So from the article as well, they talking about the previous concept. They talk about PASS, primary wound closure, agenesis, space variation, and also stability of the wound. So PASS is the ideal of regeneration bone grafting concept. So if you have been placing implant, you might heard this a lot. So that is the reason why you have to treat this patient. You have to clean, you have to remove all the problems, and then you have to put the new bone grafting materials and let this stay and heal. So once we know the wound is available to close, we have to know how to clean this implanted tissue. So by removing implant granular tissue using a curette or dental lasers, and also you have to use some medication in case you want to eliminate all the bacteria around the implant. The continuing one will be the decontamination. Once you have the old granular tissue removed, it's now to treat the implant surface properly. Unlike normal two, you have to treat the implant with a titanium-based instruments, and also implantoplasty will be an option if you want to keep this implant alive. So various instruments and burrs are capable, including titanium brushing and specific burrs. So if you have some kits, you can use the most basic one from your original dental burrs, finishing burrs, white stone, or polishing burrs. If you want to upgrade your instrument, you can find this kind of type brush. I think Straumann has it, and also some company had this kind of brush for you to clean the titanium surface of the implant body. And also one of the implant company, they also have this art brush. So basically this diameter form implant cleaner for you to brush down your implants. However, in this case, you will be doing implantoplasty, removing the coating of the implant surface. But basically you could use all this to do the decontamination of the implants. So stability of the wound, we'll be talking about how you could manage this wound when you're placing the bone graft. So in the paper, they're talking about the urban concept using the autogenous bone graft and also xenograft with a non-resorbable membrane and a bone screw-in fixation. But in my opinion, you could use whatever you like, and whatever your technique for a GBR would be a good option, because I know some countries are not allowed to use allograft. Some countries, yes. So in my opinion, I think allograft will be a better choice. I will show you the case later. So this is the case by one of pioneer doctors in Taiwan. We have a course together, and we have also the patient together to see this, to work with EPDDS. So you can see this patient has peri-implant infection. There's erythema, swelling, but no pus. And we took the X-ray, we took the radiograph, we see there's a big marginal bone loss in the area of implants. So we change to from prosthetic, we change to healing abutment. We use some blasting with glycine powder to eliminate the surface of the contamination. And then we follow up for 1 month. We have the more or less stabilized gingival margin and also a stabilized problem without any inflammation. And continue, we open our flap, we reflect it, we remove the granular tissue around the surface, around the implant, and we have to make sure everything is clean. We applied the titanium brush to decontaminize the implant surface, and then we use tetracycline paste to do the detoxification. This is a step the book doesn't talk about, but it's very, very effective. You could try, but have to be careful because sometimes detoxification using tetracycline paste, you might have causing chemical burns if you don't have calculated the time properly. So once everything is removed, we place graft, double layer graft with autogenous bone grafting, and also autogenous bone chip with allograft FBBA together to make a sandwich graft technique. We're using healing abutment to extend our tenting for our GBR area. We screw the pin, we close, we release the flap for buccal side and the lingual side to make sure we could close this wound properly as a stability of the wound, talking about with tension-free and without any contamination, without any tension of the wound. We use double layer suturing with horizontal matrix suturing and single interrupted suturing with 4.0 PDFE to make sure the wound is fully closed. That is radiograph we took that day of the operation. You could see most of the bone graft is covered the implant and also the healing abutment. That is the 10 days, 17 days, and 1.5 months of the results. You could see the swelling, the inflammation has lowered down, and we have revealed a good, healthy, nice tissue. The current tissue is kept and is well secured without any problems. Also, we have a 2.5 months. You can see the tissue is in a healthy situation. We have also asked the patient to come back once a month to clean the adjacent teeth to make sure we don't affect the GBR, any contamination. So that is the pre-operation and also the photos of 2.5 months. So that is the radiograph. You can see we have a big defect in the beginning. We place the bone graft after 70 days, 1.5 months. There's not a big loss, excuse me. There's not a big loss of the bone grafting. We are using the autogenous bone and also the FDVA. And sometimes if you use the xenograft, the result might be similar to the perioperative radiograph. But we will keep following up these cases, and I hope in future we have another chance to share with you. So to finish the whole peri-implantitis management, I have come up with a concept that is using the suppurative peri-implant therapy to help you to understand how to evaluate your patient if they have peri-implantitis. So if you have a low PIRA, the low risk assessment, you might have chance of peri-implantitis. You might have bleeding and propylene, 4 millimeters of propylene depth. Thickness of tissue is well controlled. However, some erythema is presented. If you have a moderate PIRA, will be a peri-implantitis, but favorable to treat it. If you have a high PIRA of peri-implantitis, which might be unfavorable for treating. So in this case, you might thinking about what you are going to do next. So that is also you could check out Tonetti's paper talking about risk assessment of the periodontitis. So that is more or less a modification of that into the peri-implantitis. So when you have a low PIRA, you obtain a peri-implant health. when you have a moderate PIRA, you might have perimucositis, and when you have a high PIRA, which means you have peri-implantitis and needed to be treated properly. So when you have an implant, there will be a healthy implant, no bleeding, no swelling. You might understand this is the first step. Once, maybe a half a year for a routine checkup, if you find the patient is bleeding and broken in the implant site without any bone loss, you might end up with perimucositis. You will end up with peri-implantitis. So for perimucositis, you have to remove the plug. You have to do some sandblasting, as we're talking about using a glycine powder, or you could do the non-surgical treatment. And then we do the oral hygiene care to follow up this kind of patient. But also in peri-implantitis, you also could do non-surgical therapy first. And then if you have a large defect, you might consideration of EPDDS. If the implant is already moving, this hopeless implant, you might thinking about implant removal. So for this, when you have a non-surgical treatment, you have done your EPDDS therapy, you could go into the risk assessment I just talked about, the PIRA, to understand which part should be managed. For non-bleeding, non-probing, non-bleeding, no swelling, you will just continue to follow up, will be a perfect solution. You have low PIRA, that means you still have perimucositis. You could go back to the phase of plaque removal or non-surgical treatment to make sure everything is done properly. If you have moderate PIRA, which is also a peri-implantitis, but available to keep the implant, we will go back to the EPDDS for more generative, more reconstruction. If you have a high PIRA, you might think about implant removal, and then you do the debridement, you do the GBR, and then close stability for the wound for 6 to 9 months, and you can thinking about re-implant, then back to the follow-up session, then back to the first implant management. So this will be the concept of peri-implantitis management for me, to talking about how you could differentiate the peri-implant health, the perimucositis, and also the peri-implantitis. And people might asking how will be the survival rate of re-implantation. So from Anitua's papers in 2017 and 2021, they have talking about the re-implantation. They found the implantation survives very nice with 99% of survival rate. And also if you would do the immediate implantation, 94% of survival is also very high. Although they didn't talk about, but I found out they use shorter implant comparing to the previous implant system. So you might take this into charge if you want to do a re-implantation. Maybe you could thinking about a shorter implant will be a better option. So my conclusion, my final will be many peri-implantitis, you have to prevent it before placing the implant. You have to ensure everything is under control. Everything, the surgical type is also very good. If after placing the implant, you have to know the prosthetic design is perfect. Everything is in well designed. You don't have to worry about any problems. And then if you're already facing the peri-implantitis, you have to know this will be the problem. And you have to deal with it precisely. You have to remove all the plaque, contamination, affected components, such as improper prosthetics. And also you have to make sure all the granular tissue is removed and then re-augmentation is placed. For this kind of patient, all the thing we have just been talking about is about reconstruction. Some people may ask if there is a possibility of re-osseointegration. This is still unknown. We have to make sure the implant has a well stability, and that's all for a peri-implantitis treatment. To talking about re-osseointegration, sometimes your grafting material may be affected, and also your technique may be affected. So also, last, for treating peri-implantitis, implant removal should always consider as a prior option in severe cases. Maybe you placed the implant like 2 years ago, 3 years ago, you don't want to lose it, but sometimes a better way to treat peri-implantitis is to remove it and re-implantation for the best. And always, for last, recall your implants, remember how many you place, remember how many you should follow, and don't forget your patient to come back to you. Thank you, and my gratitude to my professor, my team, for this work happening. And if you have any problems or any questions you want to ask me, feel free to contact me through email, my LinkedIn, my Facebook. And thank you for your time today. Thank you.